We as a profession have not done a very good job of getting the right treatments to the right people at the right time. And I went through a lot of the evidence of the poor quality of U.S. healthcare in many environments and the incredible variability of care that happens in the United States. It was that variability in care and consequent low quality or variable quality in care that drove people to say we need to be treating based on evidence. And so the evidence-based medicine movement was trying to figure out how do you provide the right evidence to clinicians and caregivers so that they can do the right thing at the right time for the right people. Difficulty in that is that the evidence base for the creation of the evidence that produces these kinds of guideline recommendations is not really up to the task of producing the data that it needs to produce. So most all guideline recommendations that are produced from evidence-based medicine come from randomized controlled trials. And many of the patients that I see in my own office and that most doctors see would never have been admitted to the trials that produce the data that makes the guidelines and recommendations. And so you can't believe as strongly that they apply to your patient. The real connection in my mind between evidence-based guidelines and the computerized decision support inside health records is that you have data and understanding and information that you have from a population level that says where you're not doing well, and that can tell you which populations and which subsets of the populations you need to work on the hardest, and where you can direct your work in terms of decision support and use your health IT to implement that decision support in the people who can benefit the most. I think that one of the advantages of having many of these decision support systems inside thoughtfully implemented health information technology is that we can now give patients access to that through their personal health record. And where I practice and where many people practice now, patients have relatively direct access to their own health information. And you can be just as smart about alerting patients and informing patients with alerts and reminders and thoughtful application of data to help patients understand what they need and why they need it, just as we're doing with alerts, reminders, and computerized decision support for physicians. I think we can get much smarter about delivering the appropriate message, the appropriate alert, the appropriate reminder to the person who needs it at the time that they need it. Now, you have to get a little bit careful with that because there are lots of different, I guess, philosophical beliefs about who should be doing what. And you have to be, in your own care environment, you have to be very clear about who's allowed to do what. It's HIT that allows you to think about that in a very structured way that allows you to deliver the appropriate alert and appropriate reminder to the person who needs to use it now. I believe that as we move more and more into using the wealth of information that's contained in hospital information systems or electronic health records, that we can combine the data in electronic health records, this patient-specific data in electronic health records, with thoughtful science and thoughtful statistics and thoughtful tools that can help tailor and personalize the specific recommendations and guidelines that we have to that particular patient who's sitting across from you in the exam room.